welcome all the delegates from all parts of the country to the mycology session. Dr. Dinesh has moved the ball for me, and mm, he has done my job almost half. Many times, me and Dr. Dinesh argue like how to differentiate or how do you diagnose the systemic and opportunistic infection. He has a very he always speaks like how we see, we diagnose. So he depends a lot on the skin and the subcutaneous tissues and mucous membrane. But the most difficult part for me is I can't see the liver or spleen or lung or brain. So I always speak to him what I suspect, that I diagnose. So for systemic and opportunistic infection, most important part is suspiciousness, because most of the time uh, you will not be able to see anything, but you have to suspect so that you can at the end of the day you can diagnose the. Myself, Dr. Sagar from the Department of Medicine from AIIMS Bhopal. I will give you a gross overview how and why the systemic and opportunistic infections are most important in this strata of time period, and why the workshop is being organized at this time period. To give you a gross overview, there are around 1.5 million fungal species, out of which hardly about 500 are identified to cause human disease. 1.5 million has been cut out to hardly 500. And mind it, these 500 organisms or fungi are not easy to identify, and they share so much in common, you will confuse both in diagnosis and during treatment also. There are around 300 million people across the globe who are infected by fungal infections, and there are two systemic fungal infections, and out of which 2 million people die every year. This 2 million is actually more than TB and malaria across the globe. This report has been done by GAFI, that is Global Action Fund Fungal Infection. There is a beautiful cartoon from the Journal of Fungi. Why the fungal infection has grown to such an extent for the last couple of years. Okay. If you look at, there are basically two important things that is happening in today's world. Number one, increased population at risk. So the vulnerable population has grown drastically, starting from the immunocompromised conditions of thyroid, diabetes mellitus, malignancy, transplant recipient, and you go on and on and on. And second, probably the change in environment, the global warming, the deforestation and all. So both the environment and the change in the host parameters are responsible for increasing in the systemic and opportunistic that is being increased to such an extent last couple of. Basically, Dr. Dinesh has already mentioned that fungal infections are usually read in four different parts: superficial infection and subcutaneous infection that has been dealt by Dr. Dinesh. And I will be touching some points on systemic, or more popularly called as endemic mycosis, and opportunistic. The difference between these two are systemic mycosis can infect any organ system to any host. I mean, both patients may be either immunocompromised or immunocompetent, and they are caused by fungi which are particularly located in a specific part of the world. By God's will, India, though we see some systemic infections, they are not that endemic, except that belt of Himalayan and northeastern. Opportunistic infections, they are considered non-pathogens usually. They are saprophytes, but they infect intestinal. Once you are down with immunodeficiency, these opportunistic infections, which are present all around your environment, it may be there inside you, in your skin and mucous membrane. Now they will try to invade you. They give rise to opportunistic infections. So to summarize, systemic fungal infections can infect both immunocompetent and immunocompromised patients, whereas opportunistic infections usually infect only the immunocompromised ones. The systemic fungal infections are usually seen in endemic region. In India, we see to some extent, as I have already mentioned, the Himalayan and northeastern belt, whereas opportunistic infections are seen all over the globe, all over India in the vulnerable. The systemic fungal infections are most of the time enter through the inhalational route, whereas the opportunistic infections enter both through inhalational plus other routes that I was trying to mention through your mucus. Maybe there in the GI. Coming to the diseases and agents which are caused by systemic infections, systemic fungal infections are histoplasmosis, blastomycosis, coccidioidomycosis, and paracoccidioidomycosis. And among the opportunistic important organisms are Candida, Cryptococcus, Aspergillosis, Mucormycosis is by Mucorrhizopus and Absidia, Entomophthalus, Saccharomyces mannafi, Pneumocystis jirovecii, Fusarium species, all are called as the opportunistic. Systemic fungal infections are not very common in India. Probably to some extent, histoplasma we see once in a couple of months. Opportunistic infections we day in and day out, particularly in vulnerable. Coming to the global burden, look at the numbers, the galloping numbers. Aspergillosis, 132 lakhs per year. Most of them present with ABPA, that is allergic bronchiolitis aspergillosis or fungal asthma, around 100 lakhs. Chronic pulmonary aspergillosis, 30 lakhs. Invasive aspergillosis, 2 lakhs and 50,000. Next in the number comes invasive candidiasis, around 7 lakhs per year across the globe. Pneumocystis jirovecii pneumonia, around 5 lakhs. Tropical meningitis, mostly in tail-HIV, to the tune of 5 lakhs. Disseminated diagnosis, around 1 lakh. So I would try to give you a hint of all those in the globe. There is a confusing yet most often used term by the clinicians called as invasive fungal infection. By definition, invasive fungal infections will invade the skin and mucus, but unfortunately, we mean by invasive fungal infection something called as which are systemic, which are generalized, which are deep-seated, mostly in the viscera, which are severe and life-threatening. You will find this term all over the clinical journals, whichever if you are dealing with physicians, they will be utilizing this term. Probably this is a misnomer and should not be used. What are the invasive fungal infections in India? Basically two types, either it can be yeast or a mold. Yeast, Candida is the most common, which invade skin and mucosa and enter into the bloodstream, causing candidemia. Among the molds, Aspergillus and Mucor, combinedly they are occupying to the tune of around 90% among the molds. And rest 10% are rarely by Scedosporium, Fusarium. This particular data has been taken from Sagar. Coming to Candida, Candidemia, different species differ in virulence, environmental preference, and susceptibility to antibiotics. In my first couple of minutes I was talking to you, you have to suspect To identify a systemic or opportunistic infection, you have to have a very keen eye, keen mind, and each and every sense of you give you a impulse that some fungal infection might be there in my patients. Unless otherwise you suspect by a sound scientific evidence, you cannot diagnose, because most of the time these organisms will be difficult to grow, and when you grow, you do not know whether they are really pathogenic or non-pathogenic. So Candida, the different species differ in their virulence, environmental preference, and susceptibility to antibiotics. For example, Candida albicans, which is the most common candidemia across the globe, it colonizes the GI tract and the mucosa. In contrary, Candida parapsilosis found more on the skin. So, when you think of candidemia, which is associated with a CVC line, a central venous catheter line, or patient is on a total parenteral nutrition, think of a Candida parapsilosis. The importance of Candida parapsilosis identification is there is a higher MIC of echinocandins, and you may have to give high dose of echinocandins. Candida glabrata is associated with previous fluconazole. Many patients will be taking fluconazole therapy when they are immunocompromised or for onychomycosis and all. And in these patients, Candida glabrata may invade and give you azole-resistant candidemia. Candida tropicalis are mainly associated with hematologic malignancies. So when you deal with hemato-onc, you think of Candida tropicalis. A word about Candida auris. This is a rare candemia, but this is rising very, very, very fast. And notorious candidemia, which are most of the time mechanocandin pan-resistant cases, which I am more worried about that Candida auris may give rise to cross-infection patients among the other important but less commonly found candidemia are and why there occur invasive candidiasis. So those factors are either the patient is on a prolonged period of antibiotics, right, or any other antimicrobial, increased use of steroid, total parenteral nutrition, cancer patients are on chemotherapy, they are on a central venous line or a vascular catheter, gastric acid suppression, all those who take a prolonged period, pantoprazole, omeprazole and all, aware of this. Patients having neutropenia, patients who are just completed GI surgery, who are having renal failure and on hemodialysis, these patients are mostly exposed to candidemia, and they can give rise to candidiasis. Candidemia affects around 2.5 lakh population a year with 50,000 mortality, mostly in ICU, and it has been cited as the fourth most common bloodstream infections. Of course, the first bloodstream infection have to be the gram-negative sepsis. Mortality in candidemia are about 25 to 60%. If you look at the global presence of candidemia and look at India, this data has been published by Chakravarti et al. In India, the most common organism, this is India, the most common organism, again, Candida albicans, but Candida non-albicans are fast growing in India and all across. Candida albicans is the most common organism in the first video, and in the list order are Candida tropicalis, labrata, Candida parapsilosis. What is about candemia in Asia? Incidence has increased around fivefold in last year. Developing nations 4 to 15 times higher incidence than development. So we, the developed nations in Asia, like India, got a higher prevalence. All these candidemia or any invasive fungal infections rates are probably underestimated, and there will be a huge number if we really do some sort of survey. The incidence of candidemia in Asia are from 0.026 to 4.2 cases per 1,000 admissions. And look at what happened to the developed nations. It's about one case, around one case per 1,000 cases. In Asia, around 2 cases per 1,000. ICU admissions in developing nations, around 2 to 40 cases per 1,000 admissions. And in developed nations, around 6. So there is clearly an increased incidence and prevalence of candidemia in developing nations, including India. The crude mortality rate in developed nations is around 30 to 50%, whereas in developing nations is more than 50%, in developed nations less than 50%. Again, the literature has come from Chakravarti. Canada orange, if we look at the CDC notification in February 15 of this year, this is a serious global health threat. Often MDR and PDR, difficult to identify. Most of the time they are misidentified because of standard laboratory methods are not practiced. It can cause outbreaks in healthcare sector. So we are worried about Canada orange. Coming to other opportunistic mold infections. Mold infections mortality in Canada it was around 50 to 60%, whereas in mold infections may go beyond, may touch around 90 to 95%. They are very common in HIV, AIDS, hematologic and solid organ malignancies, neutropenic non-neutropenic patients, long ICU, transplant patients, steroid use, COPD, and chronic liver disease. All these were almost the same host agents for the candidemia. Coming to the difference between aspergillosis and mucormycosis, aspergillosis may present mostly with pulmonary involvement. Either they may present with aspergilloma, it may present as ABPA, bronchopulmonary aspergillosis, allergic bronchopulmonary aspergillosis, chronic pulmonary aspergillosis, and kappa, COVID-associated pulmonary aspergillosis. This term has been designated recently. It may be invasive aspergillosis, usually caused by Aspergillus fumigatus and Niger. Sinusitis, ocular, and cutaneous all can present by Aspergillus flavus. Cerebral ear involvement may be by Aspergillus niger, and there may be fungal toxicosis, and it is usually caused by aflatoxin by Aspergillus flavus. Okay, so pulmonary aspergillosis, the most common organism is Aspergillus. Mucormycosis, you know, mostly they are rhinocerebral. They start with your sinus and they move eye and brain. It may be sometimes pulmonary, and rarely it may present with cutaneous. Look at the spectrum of involvement over the globe by CPE, that is chronic aspergillosis. India comes in the range of 14 to 18 CPA per 1 lakh population. This is a huge body, and has been taken to hedge estimation in 2020. So, looking at this picture, you are now aware that in India, it is as good as 14 to 18 patients per 1 lakh population. Some patients are having chronic pulmonary aspergillosis. Look at the mucormycosis. Dr. Sarman Singh and Dr. Dinesh Sosati were talking about mucormycosis in India. Just to have a data, India has much higher prevalence. We do not know why, but it's much higher prevalence, around 80 to 100 times higher prevalence than across the world. The data has been postulated that per 1 lakh population, like CPA, that is chronic pulmonary aspergillosis, mucormycosis, as good as 14 per lakh population, our mucormycosis. This data has been identified by the mucormycosis study by Patel et al. Recently published in 2021, where AIIMS Bhopal Right. Coming to Cryptococcus, two important cryptococci are important. One is Cryptococcus neoformans gatti. Usually, immunocompromised patients are infected by Cryptococcus neoformans, whereas Cryptococci gatti can infect the immunocompetent. Organ involvement, Cryptococcus neoformans meningitis is more common than the lung involvement, whereas the reverse for Cryptococcus gatti. Complications, they are less for Cryptococcus neoformans, more for gatti. The complications may have a cryptococoma, hydrocephalus, or a large space of fine lesion in the brain. Antifungal susceptibility, it is relatively easy to treat Cryptococcus neoformans, but very difficult to treat Cryptococcus gatti. They are not susceptible. If you look at the world incidence, again, India is one of the highly endemic cryptococcal infection countries with a prevalence of around 15,000 to 25,000 annual incidences reported as per world. Coming to Pneumocystis jirovecii, which was earlier called as Pneumocystis carinii, and the pneumonia is still called as PCP, Pneumocystis carinii pneumonia or Pneumocystis jirovecii pneumonia. About 30 to 40 population, 30 to 40% of people who get PCP have HIV and AIDS. So do not have a notion that PCP only occur to HIV/AIDS patients. Probably we are not aware that PCP can also involve non-HIV patients who are compromised. Symptoms of PCP will be like any subacute LRTI, like fever, chill, cough, shortness of breath, chest pain, and fatigue. There occurs a sudden drop in oxygen and end up in mechanical ventilation. Coming to other opportunistic infection like Acceleromycosis and Fusarium. Earlier it was called as ichthyosis, now it is called Acceleromycosis. Acceleromycosis marnefi presents the symptoms of fever, weight loss, lymphadenopathy, shortness of breath, usually liver and palpable. And Dr. Ines has shown you a picture of molluscum type butt lesion, mostly on the face and neck areas. They are endemic in Southeast Asian region. And in India, the northeastern states like Manipur, they are endemic. Fusarium, we do not see much, whereas the most common mechanism is Fusarium solanae. Immunocompetent patients can give rise to process. Immunocompromised patients, it can give rise to angioinvasive pulmonary and sinus infection. They are usually associated with cancer patients and neutro. Only 2 or 3 slides for endemic mycosis. They are not very common except histoplasmosis in India. You see once in a while sometime. Histoplasmosis presents with pulmonary, that is the most common. Once the histoplasma enters through your respiratory tract, it infiltrates the lung field, and you will get hilar lymphadenopathy, and you will get a chronic cavitary histoplasmosis, mimicking that of tuberculosis. So I am of the strong opinion that many patients who are negative and we still go on treating with tuberculosis should suspect histoplasmosis and send them some for identification of histoplasma. The extrapulmonary manifestations are also common. It may be mucocutaneous, like skin and oral mucosa, which are predominantly found in India, where we see more of oral mucosa and skin histoplasmosis. It can be disseminated in PLH. Mycosis, again, pulmonary is most common, and you get a flu-like illness most of the time, and it ends up beyond a couple of months, and it presents with a chronic lower respiratory tract like lesion, like that of histoplasma capsulatum. Histoplasma capsulatum presents with hilar lymphadenopathy and chronic cavity like that of TB, but blastomycosis doesn't do cavity. Extrapulmonary manifestations are also not uncommon. Skin, CNS, bone, prostatitis may occur. We do not see much of coccidiosis. I have never seen it. And they can involve both pulmonary and extrapulmonary sites like joint. Look at the burden of these endemic mycosis across the globe. Coming to histoplasmosis, the upper part, India, the Himalayan, and the northeastern states are almost endemic. Coming to blastomycosis, there is a possibility that whole of India may ultimately report blastomycosis. Probably we are not able to report or we are not able to diagnose. That is why blastomycosis is not much from India, and whatever being reported, they are poor quality. Coccidioides is rare if you look at this world literature. Also, coccidioides